A normal potassium is between 3.5 and somewhere around 5.5. In general, for your hospitalized patients, you want to keep your patients between 4 and 5. Potassium is used in lethal injection, so derangements of potassium are deadly. And there's a very narrow range where the potassium should be. With intact kidneys, generally the body takes care of it itself. I want to talk to you first about hyperkalemia because that one is way more complicated, and then we'll finish off with hypokalemia. What you want to do is be able to identify why they became hyper or hypokalemic, and then what you do to fix it. Talk about hyperkalemia first. There's a couple of ways you can get hyperkalemia. The first is a low aldose state. We do this to our patients by giving them medications, such as ACE inhibitors, angiotensin receptor blockers, and aldosterone antagonists. All of these medications have the side effect of increasing the potassium. You can give someone too much potassium, that is, in the correction of hypokalemia. If you give someone potassium, you can raise the potassium too high, but that's going to be really hard to do, as is ingestion. People can eat potassium. The problem is that if you have intact kidneys, the kidneys are going to take care of it. So in order to ingest enough potassium to cause a problem, you must also have some form of CKD. And with that, end-stage renal disease patients constantly have problems with potassium because the renal system is the only way your body has to regulate potassium. An end-stage renal disease patient can't get rid of potassium. And potassium is in a lot of foods, such as citrus. So as the patient consumes normal diets, the potassium will rise. And the one you should pay close attention to in the hospital is artifact. That is hemolysis. And this is a laboratory artifact, especially if someone is squeezing their fist while the blood is drawn. Now, hyperkalemia does have some signs and symptoms, but you don't really care about those. What you care about is the EKG. And I like EKG because it reminds you, potassium, check a EKG. A normal EKG has a P wave, a narrow QRS complex, and a T wave. Hyperkalemia causes the T waves to peak, then the QRS to widen. Wide QRS, peaked T waves. It can also cause heart blocks, but what you should look for are tall, peaked T waves. Essentially, you may not be able to tell the difference between the QRS complex and the T wave. That's a peaked T. If you don't correct them here, what will happen is they will go into a sine wave arrest, and if they're here, they're essentially dead. You probably will not be able to recover from this. So if you see someone who has hyperkalemia, don't freak out. The first thing you want to do is recheck, especially if you did not anticipate the potassium was elevated. The exception to this, of course, is someone comes in for a problem with an EKG and you get a potassium. Don't wait to intervene. But if you just happen to have a routine lab draw and the potassium is elevated and you don't really understand why or expect it, it's probably that artifact from hemolysis. Because if the recheck shows a normal potassium, it's not hyperkalemia, and you're done. But if it is elevated on the recheck, that is when you get the EKG. And the EKG is going to tell you if it's stable or unstable. If there are EKG changes, peak T's, widen QRS, it is unstable hyperkalemia, and you need to do something about it right now. I'll talk about the interventions in just a minute. If the EKG shows no changes, and you have a stable hyperkalemia, and and you can fix this at your leisure. Let's call it urgent. Okay, what is the difference between emergent and urgent therapy? In emergent therapy, you need to do everything. You need to stabilize, temporize, and decrease total body K. Talk about what this means in a minute. In stable hyperkalemia, you need only reduce the total body potassium. The idea is, if you have EKG changes, you start at stabilize and you do everything. Don't stop at any one point, but if there's no EKG changes, you begin and end at decreasing the total body potassium. Okay, let's talk about the different interventions we have with this framework: stabilize, temporize, and decrease total body K. Stabilization occurs with calcium. You give it intravenously, it lasts only a few minutes, and it stabilizes cardiac myocytes. If EKG changes, IV calcium. To temporize, what you want to do is shift potassium into cells. This does nothing to the total body potassium, but what it does is it takes the potassium out of the serum, so the heart can't see it, so the heart can't be impacted by it. You temporize with insulin and D50. Insulin and D50 is the preferred method. Insulin causes the K to shift into cells, and you give D50 because you're giving insulin, and they need sugar so you don't bottom them out. You can also use sodium bicarb or beta agonists. Given IV and nebulized. This lasts on the order of hours and gives you time to reduce the total body potassium. There's two ways to eliminate total body potassium. That is through the urine and through the stool. You give loop diuretics like furosemide to get rid of potassium through the urine, and K-exalate to get rid of potassium through the stool. You induce diarrhea. These take a long time to work, though, and they last on the order of hours to days. Not to say that their half-life is on the order of days, but it takes a number of doses in order to get the total potassium down. And ultimately, if someone is dialysis dependent, hemodialysis can be used to control their potassium. This is a chronic therapy that they do on a regular basis. If their EKG changes are so bad, their potassium so deranged, you can do acute hemodialysis in order to correct the potassium. Spent a lot of time on this, and this is where your questions are going to come from. What do you do? If there are EKG changes, give calcium, then give insulin D50, and give some mechanism for eliminating total body potassium. Most often when you see this, the patient is going to have either chronic kidney disease or end-stage renal disease, and so your access to loop diuretics won't work. Most of the time, it's going to be give K-exalate to get the potassium out of their system. Okay, that's hyperkalemia. Let's talk about hypo. Hypokalemia is much easier, which is why there's so little space for it on the board. Hypokalemia occurs in one of two ways. You either have renal losses or you have GI losses. GI losses occur in the form of vomiting and diarrhea. Renal losses are going to be in one of two states. Just as hypoaldo led to a hyper-K, hyperaldo leads to hypo-K. And hyperaldosterone states can be renal artery stenosis, fibromuscular dysplasia, or Conn syndrome. And then we can do it to ourselves. That is diuretics, particularly the thiazides and the loops. For those bonus points on the wards, you can also remember that there are some genetic diseases that look like diuretics. That is Barter's and Gilliman's, loop diuretic, Barter's, thiazides, Gilliman's. But those are very rare, you generally don't see them. Most of the time, you get hypokalemia simply from diuretics or from GI losses. And again, there are symptoms of hypokalemia, paralysis, weakness, but that doesn't matter. What you want to do is when you see a problem with potassium, you want to check the EKG. But here, it's much simpler because when you have a low potassium, generally what you're going to do is just replete it. The EKG changes aren't as severe as in hyperkalemia, and you might have some flattening of the T waves, but your response is not going to be to the EKG. It's going to be in response to the low value. So if you have a low K, you might think about rechecking the potassium to make sure it's real. And if it is real, checking an EKG. But regardless of the response to the EKG, you are going to replete. So what you're going to see, and of course, if there's a normal K, it's not hypo on that recheck. What you're going to see people do in practice is see a low K and jump right to repletion. So let's talk about repleting potassium. Repletion goes something like this. Oral is better than IV. If you're going to replace IV with a peripheral line, you cannot go faster than 10 milliequivalents per hour. This is because potassium burns. If you have a central line, you cannot go faster than 20 milliequivalents per hour for fear of inducing hyperkalemic symptoms to the heart. And how much you give is dependent on the current potassium. In general, 10 milliequivalents of potassium will change the potassium by 0.1. This is true when the potassium is greater than 3 and less true when it's less than 3. But what I want you to remember is 10 milliequivalents, 0.1. And lastly, if you're having problems replacing potassium, that is, you give the potassium, you give the potassium, you give the potassium, but the potassium doesn't rise, check for a mag. And replace the magnesium before or at the same time as the potassium. That's potassium.